Hello everybody. In this series of continuous cardiac education, my topic today is congenital heart disease in adults. I am Dr. Neerav Parekh and I am an associate professor in the Department of Cardiac Anesthesia at UN Mehta Institute of Cardiology and Research Center. So I would like to divide my topics into 5 sections. First is general considerations. Second would be individual organ implications, which I would divide into cardiac and non-cardiac. The third would be anesthetic considerations for a patient with adult congenital heart disease, which I would divide into preoperative, intraoperative and postoperative. The fourth will take individual adult congenital heart disease, and the fifth would be a brief about non-cardiac surgery in such patients. So we'll start with general considerations. Advances in perioperative care for children with congenital heart disease over the past has resulted in ever increasing number of these children reaching adulthood with their cardiac lesions palliated or repaired. As a result, a dedicated specialty society, the International Society for Congenital Heart Disease, was formed in the 1990s. More than 85% of the infants born with CHD are expected to grow to adulthood. These patients can be seen by anesthesiologists for primary cardiac repair following a primary palliation, revision of repair due to failure or lack of growth of the prosthetic material, or conversion of a suboptimal repair to a more modern operation. So what are the congenital heart disease which we will encounter? These are aortic stenosis, aortopulmonary shunts, atrial septal defect and partial anomalous pulmonary venous return, coarctation of the aorta, congenitally corrected transposition of the great vessels, the so-called ventricular inversion, Epstein's anomaly of the tricuspid valve, Eisenmenger syndrome, endocardial cushion defect, the so-called AV canal defects, patent ductus arteriosus, pulmonary valve stenosis, single ventricle, tetralogy of Fallot, transposition of the great arteries, the detransposition, truncus arteriosus, ventricular septal defects, and anomalous left main coronary artery. So what are the indications for cardiac surgery in adults with congenital heart disease? As we looked them previously, these would be for primary repair, total correction following palliation, revision of the total correction, conversion of a suboptimal operation to a more modern repair, and heart transplantation. In addition, these adults with CHD will be seen for other common ailments of aging and trauma that require surgical intervention. Women of childbearing age with CHD will become pregnant. They must cope up with added physiological demands of pregnancy and will require analgesia for labor and anesthesia for cesarean delivery. Even though congenital heart disease carries implications for lifelong medical problems, a significant number of these patients will not have continued cardiology follow-up despite ongoing general medical care. These patients bring with them anatomic and physiological considerations and complexities of which physicians which are accustomed to caring for adults will not be aware of. Also, many medical problems associated with aging and pregnancy will not be familiar to physicians who are used to caring for children. This is even more complicated because significant number of these patients will be unaware of their cardiac diagnosis. Having lived with the disease for many years, these patients will self-limit exercise or think themselves as asymptomatic when in fact they are not. So a major recommendation is that adult patients with moderate or complex congenital heart disease be cared for in specialized adult congenital heart disease centers. Among adults with congenital heart disease and cyanotic lesions, the leading cause of death was arrhythmias followed by heart failure. For patients with acyanotic disease, the leading cause of death until 1990 was arrhythmias, and after that it was myocardial infarction, consistent with the longer lifespan of these patients. So let us look at individual organ system implications. We will divide them into cardiac and non-cardiac. The cardiac issues which we will face are basic hemodynamic effects of anatomic cardiac lesions can be modified by time and by the superimposed effects of chronic cyanosis, pulmonary disease, or the effects of aging. Although surgical cure is the goal, the true universal cure without residual sequelae or complications is uncommon on a population-wide basis. Exceptions in these include a non-pulmonary hypertensive PDA or an atrial septal defect, probably in childhood. Although there have been reports of a series of surgeries on adults with CHD, the wide variety of defects and the sequelae from prior surgery make generalizations difficult if not impossible. Poor myocardial function can be inherent with the CHD, but also can be affected by long-standing cyanosis or superimposed surgical injury, including inadequate intraoperative myocardial protection. This is particularly true of adults who have had their cardiac repair many decades ago, when myocardial protection may not have been as good as it is today, and when repair was undertaken at an older age. Postoperative arrhythmias are common, particularly when surgery entails long atrial suture lines, and the incidence of atrial arrhythmias increases with time, either as a primary sequelae or as an indicator of diminished cardiac function. Thrombi can be found in the atria, precluding immediate cardioversion. Bradyarrhythmias can be secondary to surgical injury to the sinus node or the conducting tissues, or can be a component of the cardiac defect. So, what are the general non-cardiac issues with long-standing congenital heart disease? Potential respiratory implications are decreased compliance with increased pulmonary blood flow or impediment to pulmonary venous drainage, compression of airways by large hypertensive pulmonary arteries, compression of the bronchioles, scoliosis, hemoptysis with end-stage Eisenmenger syndrome, phrenic nerve injury with prior thoracic surgery, recurrent laryngeal nerve injury, prior thoracic surgery or very rarely encroachment of the cardiac structures, blunted ventilatory response to hypoxemia, and underestimation of PaCO2 by capnometry in cyanotic patients. What are the potential hematological implications? These are symptomatic hyperviscosity, bleeding diastasis, abnormal von Willebrand factor, artifactually elevated prothrombin, partial thromboplastin times with erythrocytic blood, artificially thrombocytopenia with erythrocytic blood, and gallstones. What are the potential renal implications? These are hyperuricemia and arthralgias. Potential neurological implications would include paradoxical emboli, brain abscess, seizures, and intrathoracic nerve injury. Risk factors for women of childbearing age would be pulmonary hypertension, depressed ventricular function, Marfan syndrome with dilated aortic root, cyanosis, severe left heart obstructive lesions, and pressure versus volume lesions. So let us look at the third aspect of this, the general approach to anesthesia for patients with congenital heart disease. As I have told previously, the best care for both cardiac and non-cardiac surgery in adult patients with congenital heart disease is afforded in a center where there is a multidisciplinary team experienced in the care of such patients and knowledgeable about both the anatomy and physiology of these diseases and the manifestations and considerations specific to adults with congenital heart disease. So they should be taken care of in specialized adult congenital heart disease centers. What are the preoperative considerations? We should review the most recent laboratory data, catheterization studies, echocardiogram, and other imaging data. The most recent office letter from the cardiologist is very helpful. Draw a diagram of the heart with saturations, pressures, and direction of blood flow. This often clarifies complex and superficially unfamiliar anatomy and physiology. Avoid prolonged fasting if patient is erythrocytotic to avoid hemoconcentration. No generalized contraindication to preoperative sedation is there. What are the potential vascular issues which the anesthetist would face? Let us look at each one of them. Femoral veins. These might have been ligated by catheterization was done by cut down. Large therapeutic catheters in infants often cause thrombosis of the femoral veins. The inferior vena cava. In some regions, particularly when associated with heterotaxy, these have discontinuity of the inferior vena cava, so we will not be able to pass a catheter through the groin. Left subclavian and pedal arteries, the distal blood pressure will be low in the presence of coarctation of the aorta or following subclavian flap repair, or if there is postoperative recoarctation. The blood pressure will be low in classic Blackop-Taussig shunt on that side and variably so in the modified Blackop-Taussig shunt. For the right subclavian artery, blood pressure might be artificially elevated with supravalvular aortic stenosis. The superior vena cava, there is a risk of catheter-related thrombosis with the Glenn procedure. Intraoperative. Intraoperatively, large bore intravenous access is essential for reduced sternotomies and cyanotic patients. Avoid air bubbles in all intravenous catheters. There can be transient right to left shunting even in lesions with predominant left to right shunting. So filters for intravenous access are available. Apply external defibrillator pads for reduced sternotomies in patients with poor cardiac function. Appropriate endocardiac prophylaxis, both oral and or IV, is needed before skin incision. Consider antifibrillatory therapy, especially for patients with prior sternotomy. Transesophageal echocardiography for cardiac operations is a must. Modulate pulmonary and systemic vascular resistances as appropriate pharmacologically or by modifications in ventilation. What are the post-operative considerations? Appropriate pain control, because cyanotic patients have normal ventilator response to hypercarbia and narcotics. Maintain hematocrit appropriate for arterial saturations, and maintain central venous and left atrial pressures appropriate for altered ventricular diastolic compliance or the presence of beneficial atrial level shunting. The most important take-home message here is that the PO2 may not significantly increase with the application of supplemental oxygen in the face of right to left shunting. Similarly, neither it will decrease much with the withdrawal of oxygen in the absence of lung pathology. So we'll now look at individual adult congenital heart disease. We'll start with aortic stenosis. Valvular aortic stenosis is the most common congenital heart defect. Most aortic stenosis in adults is due to congenital bicuspid valve. Once symptoms of angina, syncope, near syncope or heart failure develop, survival is markedly shortened. Median survival is 5 years after the development of angina, 3 years after the development of syncope, and 2 years after heart failure. Anesthetic management of aortic stenosis does not change whether the stenosis is congenital or acquired. The second one is aortopulmonary shunts. Depending on their age, adult patients may have had one or more shunts to palliate cyanosis during childhood. Although life-saving, these shunts had considerable shortcomings in the long-term run. All were inherently inefficient because the oxygenated blood returning to the pulmonary veins to the left atrium and the ventricle would then return to the lungs through the shunt, thus volume overloading the ventricle. Also, it was difficult to quantify the size in Waterston shunts and pot shunts. If too small, the patient was left excessively cyanotic, and if too large, there was pulmonary overcirculation with the risk of developing pulmonary vascular disease. At present, in the current era, only two shunts are routinely used. These are the modified Blackock thoracic shunt and the central shunt. There are also surgical implications when complete repair becomes possible. Takedown of Waterston shunt and pot shunt was difficult. Patient with a classic Blackock shunt always had lack of palpable pulses on the side of the shunt, and the arm and length can be mildly affected. Even if there is palpable pulse, blood pressure obtained of the arm will be artifactually low. Also, in the modified Blackock thoracic shunt, there can be a blood pressure disparity between the arms. So, the take-home message here is preoperative blood pressure should be measured in both the arms with patients who have had shunts. We'll now look at atrial septal defect and partial anomalous pulmonary venous return. The most common type is secundum type, located in the mid-septum. The primum type, located at the lower end of the atrial septum, is a component of endocardial cushion defects, so the most primitive of which is the common atrioventricular canal. The sinus venosus type, located high in the septum near the entry of the superior vena cava, is almost always associated with partial anomalous pulmonary venous return. The most frequent drainage is of the right upper pulmonary vein to the superior vena cava. An uncommon atrial septal defect occurs when the blood passes from the left atrium to the right via an unroofed coronary sinus. Both the natural history and the post-operative outcome of ASDs and the physiologically related partial anomalous venous return are similar. Because the symptoms and clinical findings of ASD can be quite subtle and patients often remain asymptomatic until adulthood, ASDs represent 1/3 of all the congenital heart disease discovered in adults. Although asymptomatic to adulthood, significant shunts will probably cause symptoms over time, and paradoxical emboli can occur throughout defects with smaller shunts. Effort dyspnea occurs in 30% by the third decade, and atrial flutter and fibrillation in about 10% by age 40. The avoidance of complications, particularly developing in adulthood, provides a rationale for surgical repair for asymptomatic children. Large unrepaired defects can cause death from atrial tachyarrhythmias or right ventricular failure in 30 to 40-year-old patients. With the decrease in left ventricular diastolic compliance accompanying the systemic hypertension or coronary artery disease that is common with aging, left to right shunting increases with aging. Pulmonary vascular disease typically does not develop until the age of 40, and mitral insufficiency can be found in 15% of the patients. Paradoxical emboli, as I said previously, remains a lifelong risk. Late closure of the defect after the age of 5 years has been associated with incomplete resolution of right ventricular dilatation. Left ventricular dysfunction is also reported in patients who have had the defect closure in adulthood, and closure, particularly in middle age, may not prevent the development of atrial tachyarrhythmias or stroke. Survival of patients without pulmonary vascular disease has been reported best if operated before 24 years of age, intermediate if operated between 25 and 41 years of age, and worst if operated thereafter. Surgical morbidity in these patients is primarily from atrial flutter, atrial fibrillation or junctional rhythm. The current practice is to close these defects in the catheterization laboratory via transvascular device, and this is particularly true if there is an adequate rim of septum around the defect and there is no anomalous pulmonary venous drainage. Although some discussion is given to the onset times with intravenous or inhalation induction agents, clinical differences are hard to notice with modern low solubility volatile agents. Thermodilution cardiac output reflects pulmonary blood flow, which is in excess to the systemic blood flow. Pulmonary artery catheters are not routinely used, and patients generally do tolerate any appropriate anesthetic. However, particular care should be given to patients with pulmonary artery hypertension or right-sided failure. Most women with ASD tolerate pregnancy well. So let us summarize the complications of atrial septal defect in adulthood. These are paradoxical emboli, effort dyspnea, atrial tachyarrhythmias, right-sided failure with pregnancy, pulmonary hypertension, increased right-sided failure with decreased left ventricular compliance with aging, and mitral insufficiency. Now let us look at anomalous left main coronary artery. Anomalous coronary arterial lesions comprise a spectrum of defects. In one variant, the left main coronary artery, the LMCA, originates from the pulmonary artery. The clinical presentation is heart failure secondary to left ventricular ischemia and generally occurs in the first few months of life. A more insidious but potentially lethal form is of the anomalous coronary artery lesion when both coronary arteries arise from the aorta but from abnormal locations. So the most well described here is the anomalous LMCA that originates from the right coronary sinus. It can be from a separate ostium or may share the same ostium as the right coronary artery. This is the figure of the anomalous origin of the left coronary artery. The abnormal path taken by the anomalous left coronary artery explains why the clinical presentation is sudden death, most often during exercise. What happens during exercise is that there is increased blood flow resulting in dilatation of both the aorta and the pulmonary artery. And these dilation can compress the left main coronary artery between the aorta and the pulmonary artery. Alternatively, if the left main is intramural, it can be compressed within the wall of the aorta. So in either case, leads to ischemia in the entire territory of the left main coronary artery with sudden cardiac death. Now let us look at coarctation of the aorta and its complications. Unrepaired coarctation of the aorta in the adult brings with itself significant morbidity and mortality. Mortality is 25% by the age of 20 years, 50% by the age of 30 years, 75% by the age of 50 years, and 90% by the age of 60 years. Coarctation is accompanied by a bicuspid aortic valve in majority of the cases. What are the complications of aortic coarctation in adulthood? These can be left ventricular failure, premature coronary atherosclerosis, rupture of cerebral aneurysm, aneurysm at the site of coarctation repair, complications of associated bicuspid valve, and exacerbation of hypertension during pregnancy. Congenitally corrected transposition of the great vessels, the ventricular inversion or the L transposition. Transposition in this context refers solely to the fact that the aorta arises anterior to the pulmonary artery. It bears no reference to the origin of the blood in the aorta or the pulmonary artery or to the ventricle of origin of those vessels. In L transposition, as a consequence of the embryonic heart tube rotating to the left, that is levo rather than the right, the flow of blood is through the normal vena cava to the right atrium, through the mitral valve to the right-sided morphological left ventricle, to the pulmonary artery, through the pulmonary circulation to the left atrium, through a tricuspid valve to the left-sided morphological right ventricle, and thence to the aorta. The L refers here primarily to the fact that aorta originates anterior and to the left of the pulmonary artery. Although anatomically altered, the physiological blood flow is appropriate and there are no shunts. L transpiration of the great vessels is commonly associated with a ventricular septal defect, subpulmonic stenosis, heart block, or systemic AV valve, that is the tricuspid valve regurgitation. In the absence of any of these associated cardiac defects, LTGV is usually asymptomatic through infancy and childhood and maintain normal biventricular function. However, the relatively thin-walled morphological right ventricle is not suited to eject blood against systemic pressures. Over a lifetime, the right ventricle can fail and the patient will develop heart failure. Over the past few years, an alternative surgical approach has been utilized in some centers to avoid a systemic right ventricle. If an associated lesion has allowed for a hypertensive left ventricle, or if the left ventricle has been prepared by a pulmonary artery banding, an anatomic repair can be undertaken by means of an atrial switch plus arterial switch or a Senning plus Rastelli operation, resulting in a systemic morphologic left ventricle. Let us look at Epstein's anomaly of tricuspid valve. This defect, one of the arrested or incomplete delamination of the embryonic tricuspid valve from the right ventricular myocardium, results in a apical displaced valve tissue, and this is the most common cause of congenital tricuspid insufficiency. The septal leaflet tends to be the most dysplastic. The anterior leaflet tends to be the large and redundant. The defect is associated with the patent foramen ovale or a secundum ASD. Symptoms will vary based on the amount of displacement of the valve and the size of the smaller than normal right ventricle. Cyanosis from atrial level right to left shunting can be a neonatal phenomenon resolving with the normal postnatal decreases of the PVR, only to recur in adolescence or adulthood. About one of them developed tachyarrhythmias, which are mostly supraventricular. Once the symptoms develop, the disability rapidly progresses. Valve repair is the current treatment of choice. In Eisenmenger syndrome, in physical examination, we'll have the loud pulmonary component of the second heart sound, single or narrowly split second heart sound, Gram-Stein's murmur of pulmonary insufficiency, and the pulmonary ejection click. In chest radiography, decreased peripheral pulmonary artery markings with prominent central pulmonary artery vessels will be there, so-called pruning. ECG will reveal right ventricular hypertrophy, impaired exercise tolerance, exertional dyspnea, and palpitations are the symptoms and signs which we'll encounter. The complications result from erythrocytosis, hemoptysis, complications from paradoxical embolism, syncope due to inadequate cardiac output or arrhythmias, and heart failure. Now let us look at the Fontan physiology in brief. In 1968, performing the operation that now bears the name, Fontan and colleagues proved that it was possible to deliver the entire systemic venous return to the lungs without the benefit of a ventricular pump. The Fontan operation was thus a landmark operation in CHD because it established a normal series circulation in patients with a single ventricle. The price to be paid for a series circulation is the unique physiological demand of passive pulmonary blood flow. What are the complications which we will encounter? They are atrial thrombus, atrial arrhythmias, which can be tachyarrhythmias or bradyarrhythmias, ventricular dysfunction, chylothorax, or a protein losing enteropathy. General management principles for patients with Fontan physiology include maintenance of preload. Prolonged fast without intravenous hydration should be avoided. Regional and neuroaxial techniques are attractive options with appropriate volume status. A neuroaxial anesthesia should be avoided if a high level of block is required. A slowly titrated epidural is preferable to a rapid acting spinal anesthetic. Airway management must be skilled to avoid hypercarbia and elevations in the pulmonary vascular resistance. Adequate levels of anesthesia must be established before laryngoscopy to avoid tachycardia. Spontaneous ventilation that augments pulmonary blood flow is desirable but should not be pursued at all costs. Spontaneous ventilation with deep levels of anesthesia will result in hypercarbia, which will in turn increase the PVR, which must be avoided at all costs. A plan must be there to treat tachyarrhythmias. Patients with pacemakers must have the device interrogated before surgery so that cautery is not interfered with. If large volume shifts are anticipated, invasive monitoring with central venous lines and transesophageal echocardiography is recommended. An appropriate plan for postoperative pain management should also be established. The need for anticoagulation in many Fontan patients may preclude the use of epidural analgesia. Patent ductus arteriosus. Beyond the neonatal period, spontaneous closure is uncommon. A risk of long-standing moderate to large PDA is volume overloading of the left atrium and the left ventricle, with the risk of development of pulmonary vascular disease. Unrepaired, the natural history is for 1/3 of the patients to die of heart failure, pulmonary hypertension, or endocarditis by the age of 40 years and 2/3 by the age of 60 years. Although small PDAs are of no hemodynamic consequence, even small PDAs can carry high endocarditis risk. So surgical closure should be considered for all adults with PDA. Transvascular closure is possible and currently the treatment of choice unless there is an abnormal anatomy. Small PDAs do not carry a hemodynamic risk for pregnancy. The decrease in systemic vascular resistance accompanying pregnancy could lead to right to left shunting in a woman with a large PDA. Let us look at pulmonary valvular stenosis. Long-term asymptomatic survival is typical of such patients except for neonates with critical stenosis. With aging, however, right ventricular fibrosis and failure can develop, and this is the most common cause of death, usually in the 4th decade. Almost all patients would have relief of stenosis either surgically or by balloon valvuloplasty, and these patients will have normal right ventricular function postoperatively, although surgical reinterventions might be required. Percutaneous pulmonary valve implantation is also one of the treatment methods of choice. The development of isolated pulmonary valve stenosis is usually well tolerated in pregnancy. In many patients, significant right ventricular hypertension resulting in right ventricular ischemia can occur. Tetralogy of Fallot. The risk factors for sudden death after repair of the tetralogy of Fallot are repair requiring ventriculotomy, older age of repair, severe left ventricular dysfunction, postoperative right ventricular hypertension, wide open pulmonary insufficiency, and prolongation of the QRS. Let us look at the detransposition of the great arteries. In detransposition of the great arteries, there is a discordant connection of the ventricles and of the great arteries. The aorta with the coronary arteries arises from the right ventricle and the pulmonary artery arises from the left ventricle. Thus, these two circulations are separate. Postnatal survival requires interchange of blood between these two circulations, typically via patent foramen ovale and or a PD or VSD. So with a 1-year mortality approximating 100%, all adults with deep transposition have had some type of surgical intervention. Older adults will have had an atrial type repairs, the mustard or the setting operation, whereas children born after the mid 1980s would have been repaired by the arterial switch operation. Some also would have been repaired of the detransposition with a moderate to large VSD by means of a Rastelli operation. Truncus arteriosus. Truncus arteriosus derives from lack of septation of the embryonic truncus arteriosus into aortic and pulmonary components, resulting in a single great vessel, the aorta, arising from the heart with a truncal or a semilunar valve. The truncal valve is an amalgamation of the pulmonary and the aortic valves and therefore contains between 3 to 6 cusps. Truncal valve insufficiency is a common finding with morphological abnormal valve. A large malaligned type VSD allows filling from both the ventricles and the pulmonary arteries arise from the ascending aorta. Types 1 to 3 are the most common. Sometimes the type 4, which is the pseudotruncus, is encountered, which describes the situation of the pulmonary atresia with VSD and supply of the pulmonary arteries from large collaterals originating from the descending aorta. Repair is by closure of the VSD and connection of the right ventricle to the pulmonary artery by a conduit containing a homographed valve. The one year survival is less than 10%. Because of the very high risk of congestive heart failure following a pulmonary vascular disease in childhood from high pulmonary blood flow from the aorta, essentially all patients who survive to adolescence have had surgical repair or an inoperable pulmonary vascular disease. The rare exception to this is patients with stenosis near the origin of the pulmonary arteries from the aorta. There can be ongoing problems with incompetence or stenosis of the truncal valve or stenosis and incompetence of the homographed conduit, which will require replacement. Aortic dilatation in adulthood will also require surgical correction. Now let us look at ventricular septal defects. More than 75% of the small and moderate ventricular septal defects close spontaneously during childhood by a gradual ingrowth of the surrounding septum. Of those that close spontaneously, almost all have closed by 10 years of age. Other mechanisms for natural closure include closure by a tricuspid valve, closure by a prolapsed aortic leaflet, and closure by endocarditis. Some ventricular septal defects result in the development of aortic insufficiency in adults from prolapse of the aortic valve into the defect. Although the risk of endocarditis is ongoing, there is no hemodynamic risk of a small VSD in an adult. If pulmonary vascular disease is present, it can progress if closure of large VSD is delayed. The ventricle successfully remodels from chronic volume overload if surgical correction is done by 5 years of age and perhaps by 10 to 12 years of age. Iatrogenic heart block is also a possibility with surgical correction. If significant pulmonary hypertension has developed, closure can sometimes be done by a means of a unidirectional valve patch. Percutaneous closure devices are also used for certain types of VSDs. So my last section would be non-cardiac surgery in adults with congenital heart disease. What are the problems and difficulties which we'll face for non-cardiac surgery in such patients? The high-risk patients would include those with Fontan physiology, cyanotic disease, severe pulmonary artery hypertension, complex disease with residue such as heart failure, valve disease, or the need for anticoagulation, or the potential for malignant arrhythmias. These patients are challenging to the anesthesiologist when a non-cardiac surgery is undertaken for such adults. Thank you.